Okay, so reproductive system. This is just a revision of the physiology and anatomy, testes, epididymis, vas deferens. What's the function of each one of those? Obviously, testes responsible for production of sperms and androgen. Epididymis is where the sperms will become maturated. Vas deferens will transport sperms to the urethra. Seminal vesicle secrete fluid that nourishes the sperm. Prostate secrete prostatic secretion. Cowper's gland secretes alkaline mucus, and the penis is to ejaculate the semen. Basically, if you wanted to put this all together, the testes is for sperms and androgen. Epididymis for maturation. Anything else for secretion. Okay? All other glands for secretion. So the semen is all these secretions together. You have the sperm, okay? And then the prostate will add some more fluid to it, making the semen. The seminal vesicle will add more. And the bulbourethral glands will add more. So these three glands together are going to add the rest of the fluid part of the semen. This is just a revision of what we're talking about. These are the testes, this is the epididymis, this brown here is the vas deferens, goes all the way, and this is the seminal vesicle that's going to secrete and join the vas deferens to make the ejaculatory duct, which is this duct within the prostate, and this will join the prostatic urethra and then go to the penile urethra until it's ejected out. So the sperm start from here, from the testes, seminiferous tubules, to the epididymis, head, body, tail, vas deferens, ejaculatory duct, penile or spongy urethra to the outside. Male hormones, FSH and LH, in both males and females, but they have different function. FSH and LH are produced from the pituitary gland, and FSH will stimulate spermatogenesis in males, and in females, luteinizing hormone will stimulate the testosterone. Testosterone is the main male hormone. So it's responsible for maturation of the sperm, 6 characters, protein metabolism, muscle. So it's a musculizing hormone. Okay, it's the hormone of the males. Abnormalities. If you look at this picture here, I added it just to show it. Epispadias versus hypospadias. This is a normal. This is the penile urethra opening at the glans penis here. If it opened before that and under, in the under surface, this is called hypospadias. If it opened up here, that will be called epispadias. And the problem with that is there is a sphincter, so if it open out here, it can open and close, so the infection is not easy to happen and it is controlled. If that's not the case, it has to be surgically corrected, otherwise infection and incontinence can occur. So surgery is always the rationale, or always the treatment. Cryptorchidism or cryptorchidism, this is undescended testes. Undescended testes. Where is the in the fetal time? Where is the testis located? Is it in the scrotum? No. Where is it? Where do we have it first? At the beginning. It is in the pelvis, in the pelvic region. Okay, and it starts to descend and move. Okay, through the inguinal canal and go descend, and settle down at the scrotum at the end, after birth or at the last week of pregnancy. It's not the case. So normally it's not there. It moves from the pelvis, it starts to move and goes all the way until it settles down in the scrotum. And if that's not the case, whether it's one or two, whether these are the 2 testes in the pelvis, they started to move down, go to the scrotum and settle down. How about one of them undescended? So it can be unilateral or bilateral. What's the problem? The problem is the testes need a temperature that's a little bit less than the body. This is the optimal temperature, and it has to be like this. Okay? So what if the testes are in the scrotum, which is outside of the body, it will be a little bit colder, which is perfect for the testes. If it stay up, it's hot. We know that the core temperature of the body is higher than outside, right? At least 1 or 2 difference. So if that's the case, it's exposed to extra heat, and this can be carcinogenic. So the problem with the undescended testis is, if it stayed up there, just give it like 6 months or something, and it can produce cancer. Okay, because of the high body temperature, undescended testis. Some people have ectopic testis, which is positioned somewhere outside of the scrotum, whatever it is. Can go up in the pelvis or something, and that's called ectopic. Ectopic means out of the normal position. The cut age for testicular cancer is 5 years. So, I don't know if you know that or not, if you had a male baby before, the doctor has to feel the scrotum and see if the testis is there or not, right? Because if they leave it, if it stays 5 years, that's the maximum. Before that, they can actually surgically pull it down, and it can be successful, or even if they cut it, if they get rid of it. Better than leaving it there, because after 5 years, it will become cancerous, just like this. So here it is. It's formed here in the pelvis, and it descends down in the inguinal region, inguinal canal, moving down, down, down until it gets to the scrotum and settle down here. If it stay in one of these locations, you call it undescended if it is here. Otherwise, it can be ectopic. So it can be in the pelvic region, in the inguinal region, and even in the upper part of the scrotum is not good. It should go all the way down. Hydrocele, spermatocele, varicocele. All of them end with cele. Cele means cyst. Cyst contain watery fluid, hydrocele. Cyst contain semen and sperms, spermatocele. Cyst contain blood, which is the veins become distended with blood. This is called varicocele. These are 3 different conditions that we need to learn about. If you look at this picture here, I added it. You can take a look at it. Just Google it. So here it is. These are the veins or the venous drainage of the testes, which is located here in the spermatic cord. If for some reason they become distended with blood, engorged with blood, and start to descend and the blood stay there, they call it varicocele. And the problem with the varicocele is it can lead to infertility. Why? Because these veins contain more blood that is warmer. So this warming effect will depress or suppress the testes, and this can lead to infertility. Varicocele, so it should be treated. And varicocele can due to either the valves of the veins are weak, so the blood keeping going down, or it can be exaggerated by unrelieved sexual desire, that the congestion occur and then it's not relieved. So it stay for some time and causing varicocele. If you look at this picture here, this is spermatocele. This. So spermatocele is a cyst under the epididymis. Okay, and the sperms can be stored, and the semen can be stored in this cyst. Hydrocele, which is this one here. Hydro means water, so this is a cyst that contain watery fluid, and it's between the 2 layers, which is tunica vaginalis and tunica apogenia. These are the 2 layers that surrounding the testes. If watery fluid accumulated in there, this is called hydrocele, and the problem with any one of those is pressure. It can make pressure on the testes, and it can lead to infertility. The next thing is torsion of the testes. If the testes are torted or torsion happen to the testes, meaning it rotates around the spermatic cord. So the veins and arteries will be compressed, and this can cause ischemia. And it can be either corrected manually. The doctor can rotate it back to position. If it's been there for some time, it can get fibrotic, and it might need surgery. Okay. So this is hydrocele, this is varicocele, this is torsion. Okay. So the testis is like this, and it's hanging by the spermatic cord. If for some reason started to rotate around, the blood supply will decrease, and it can cause ischemia. Okay. Next thing is prostatitis. What's prostatitis? Inflammation of the prostate. Okay. It can be either due to bacteria or not. If it is bacterial, you call it bacterial prostatitis, and it can be acute or chronic. If it is not due to bacteria, some other reason, you call it non-bacterial. Sometimes you call it sterile or sterile, meaning there is infection, and you take a sample, you don't see any bacteria. So it's called non-bacterial, and sometimes it's asymptomatic. So prostatitis can be acute bacterial, chronic bacterial, non-bacterial. If it is acute bacterial, pain and swelling. It will be painful, tender, and swollen. Just like anything else. Anything in our body. Any infection in the body. It will be swollen and pain and tender. This is anything. Not only prostate. Okay, so this is acute prostatitis. It will be swollen and tender. And you will actually see bacteria in the urine or the secretion. Non-bacterial, you will see only leukocytes. So they get a sample of the urine, they look under the microscope, they see the white blood cells a lot, but no bacteria. This is called non-bacterial. If it is chronic, it can cause dysuria. Why? Because it's been there for some time. So fibrosis can occur. And the prostate, do you remember how the urethra goes within the prostate? So if the prostate starts to fibrotic a little bit, it can actually squeeze. It can close the urethra even a little bit, and that can cause dysuria. And dysuria means painful, hard urination. And of course, frequency and urgency can occur. Why? Because it is closing, it's pushing on the urethra, so those people urinate a little bit and they think they are done. But actually the urine is stored above that and it didn't go yet. So they go 7, 8, 10 times a day because the urine is stored, and they always feel that they want it to go, which is called the urgency, frequency. And when they go, they have some pain and difficulty, which is called dysuria. Most common organism is E. coli. Okay, remember this, E. coli. This is the most common cause of prostatitis. It can be Pseudomonas proteus or Strep, but the most common is E. coli. And they always treat prostatitis as E. coli, which is gram-negative. So they give them antibiotic for gram-negative organisms. The problem is E. coli, this E. coli is normal flora. This is a normal flora. It's supposed to be there, but it does not attack us unless we're having a problem. There has to be something that encouraged these E. coli, just like the Candida. Why would anybody like Candida vaginitis, for example? Why the vagina is infected with Candida? Is it Candida living in there already? This is the normal? Yes, there is something that is encouraging them, like diabetes, depressed immunity. Something happened to encourage them to attack, rather than just being a normal flora that's staying there without doing any harm. E. coli is the same thing. E. coli, they live inside our body. They live in the urinary system, not causing anything. They live within our digestive system, not causing any problems. But if they are encouraged for some reason, they will start to attack prostatitis. And prostatitis is more common in young men, older people if they have hypertrophy. But younger people, because they are more sexually active, they are more predisposed to different types of infections. Somebody having catheter that's not clean, bacteremia, somebody is having unsafe sex with some people who's infected, sexually transmitted disease. And if you look at this picture here, look, here is the urethra going just normal, everything is okay, the urine leave, go to the prostatic urethra, from which is go to the penile urethra, everything is fine. Here is a prostatitis, it's inflamed and it's swollen, press, so the urine will always stay in the bladder. A little bit of it is excreted, or a little bit of it is evacuated, and the rest will stay there. Prostatitis, of course, just take everything logic. Prostatitis, obviously the prostate is painful, and obviously it is compressing the urethra, so there has to be some frequency and urgency and dysuria and so on. The urine stream will be decreased. So this person or this male go to the doctor and say, are you urinating fine? Yeah, but the stream is very weak. I stay like for some time, like 3-4 longer time than I used to. The stream is very weak because if it's squeezed within the enlarged prostate. Discomfort, anorexia, and other things, but the most specific, always in any one of these diseases, remember the more specific. Okay, anorexia, a little bit of a fever, a little bit of a pain, tenderness, yeah, that's all common. But what's specific about this? Urgency, frequency, dysuria. That's something specific for this condition specifically. Of course, if it is bacterial, you give it antibacterial. If it is inflammation, give it anti-inflammatory. Balanitis, this is a fungal infection of the glans penis, okay? And it is a sexually transmitted disease. Candida, again, Candida is not it's supposed to be living there, no problem, but something happened, larger amount came, so it can cause infection, fungal infection of the glans penis. That will form some vesicles on the glans penis, burning and itching, and obviously the treatment is antifungal, and the treatment is always common sense. You have bacterial infection, give it antibacterial. You have fungal infection, give it antifungal. You have inflammation, give it anti-inflammatory, right? So it's just common sense. Antifungal, topical. BPH. BPH is benign prostatic hypertrophy. I think this is very common, and we hear about it in a lot of older people. It affects a huge percentage, like 20-30% or maybe more of people above 65. It's benign hypertrophy of the prostate. The prostate is increased in size, the size increased, but it's not malignant, it's benign. And of course, same thing, start to compress on the urine, and the rationale behind that is hormonal disturbances. Hormonal disturbances. Okay, estrogen increase or testosterone, it's imbalance in general, and it is benign. It does not predispose to cancer. Does not. Okay, benign because it affects like 30% of the population or something. So it's not pre-malignant. So obviously, because it's in the way they diagnose this, it's enlarged really, sometimes double or something, and they go in the PR examination, they go in the rectum, and they can feel it if it is really large. It's benign prostatic hypertrophy. And the main difference, even though both of them are enlarged, both of them will affect the urine stream, right? Urgency, frequency, dysuria, both of them. But the bacterial or the infection will have fever beside that, and some pain as well. This is not painful because it's not infection, it's hormonal, right? The other problem is, if you look at this picture here, if you blocked the prostatic urethra, the urine will stay in the bladder, and you get rid of some of it, and the rest is accumulating. The problem is, it can accumulate more and start to fill the bladder. You don't feel it, and it start to actually go through what's bringing the urine from the kidney to the bladder. The ureter. It starts actually to leave the bladder and go up in the ureter. Leave it more, up. Leave it more. It will go reflect on the kidney itself. So the urine starts to accumulate in the kidney. And this is called hydroureter or hydronephrosis. The ureter should be empty. We shouldn't have anything in the ureter. Same thing for the kidney. We're not supposed to have it in the kidney. Accumulating can lead to renal failure, kidney failure, because the urine is backing up all the way to the kidney itself. Okay? This, of course, can lead to recurrent infection because the urine staying there, the urine is irritant, and on top of it we can have some infection, and the infection can go up all the way from the bladder, which is the cystitis, to the ureter, which is urethric infection, and goes all the way to the kidney. Problems all related to the urine. Slow or stream is weak, frequency, urgency. What's nocturia means? Nighttime urination. Are we supposed to go to the bathroom at nighttime? Up to 2 times is okay. You don't consider this nocturia. If you go none, once, twice, that's okay. Okay? Depend on how much water did you drink and the activities and other things. But up to 2 is okay. Beyond that, that's not okay. That's called nocturia. So you go to the bathroom 4 or 5 times during the night. Treatment. They give agents something like dutasteride. Dutasteride is something to deal with a hormonal imbalance, basically. And they can get relaxant, muscle relaxant, to relax the muscles of the sphincter and of the urethra. Something like tamsulosin, which is muscle relaxant. Sometimes you get a combination of different medications. At the end, it deals with the hormonal imbalance and muscle relaxant. Cancer of the prostate. This is the most common cancer in men above 50. Very common. It's the most common above 50 in males. And it's the 3rd leading cause of cancer death in men, affecting 1 in 6. So it is very prevalent. Is the tumor differentiated and undifferentiated? If it's undifferentiated, it's more aggressive. And generally speaking, when we talk about male and female reproductive system, cancers of male and female reproductive system, they usually ask this question. They have to find out, is it sensitive to hormones or not sensitive to hormones? If it is sensitive to hormones, means the hormone is playing a role in encouraging the cancer. So they can give a treatment to depress the hormone. If it is not sensitive, so let the hormone alone and deal with it surgically, chemotherapy or radiotherapy. There are some inherited mutations in this, and it can be invasive and can be related to androgen, and it's basically the same symptoms of infection of the prostate. It's basically it is swollen, so it is compressing the prostatic urethra, but it can have hard nodule at the periphery of the gland. And basically, when somebody's having a prostatic problem, they do the PR, they go and feel the prostate. If the prostate is enlarged but everything is homogeneous, this is benign prostatic hyperplasia. If it is painful, this is infection. If they feel a nodule that's protruding, this might be a cancer. And just generally speaking, is when you have a swelling that is painful, is that a good sign or bad sign? It's a good sign. Most likely, if there's something painful, it's not cancerous. Cancerous is usually not painful. So there are some markers that can tell if of course it's not definitive, but one of them is prostate-specific antigen, PSA. A lot of people do it above 50 or something, and this can tell you if it is increased. It does not mean it's cancer, but it means you need further investigation. It might be. Okay, ultrasound, biopsy, and the most common secondaries will be to the bone. So prostate secondaries go to the bone, so they need to do a bone scan. Of course, cancer surgically treated. Sometimes they might do radiotherapy if it is androgen sensitive, so they can give something to eliminate androgen for somehow, like orchiectomy. What's orchiectomy means? What's orchi means? Huh? Testes, yes. So what's orchiectomy? removal of the testes. Why? Because it's secreting androgen, and androgen stimulating the cancer. So how about instead of stimulating the cancer, we get rid of the source of androgen, so that the tumor will decrease in size and then get rid of it. Okay, so orchiectomy, sometimes they do chemotherapy, radiotherapy. Cancer of the testes, most of the testicular tumors are malignant, and this is a problem. Most likely, a tumor is malignant in the testes, and most likely it is a solid tumor. Testes can be of the mixed type of cells. This is the origin. Teratoma is mixture of different germ cells. This is different than malignant carcinoma of the testes, which is one type. Malignant tumor can secrete those markers, and those markers are important, by the way. HCG or AFP, this lead us to think about testes. PSA, and this is a simple blood test. I'm fearing or I'm thinking about prostatic cancer or something because of my parents or somebody like that. Let's get a blood sample and see your PSA is high, prostate specific antigen. So maybe, it doesn't mean it is, it means maybe. HCG, AFP, this leads us to think about testicular cancer. Does it mean they have testicular cancer? No. It means you need further investigation. You maybe have. Spread, it usually go to the lymph nodes first. Common iliac and para-aortic lymph nodes, then to the mediastinal, supraclavicular, and then go to the blood, lung, liver, bone, brain. Generally speaking, metastasis. When you hear metastasis, or you hear that the cancer is spreading, generally speaking, not only this, the rule of the thumb is, usually when the cancer leaves the original spot, it goes to the lymph node first. The regional lymph nodes, the lymph nodes that are draining this area, lymph nodes. From these lymph nodes to the general lymph nodes, the larger lymph nodes, from which to the blood. From the blood, it goes to 4 spots, 90-something%, and you can just say those four, and most likely you get it right. BBLL, lung, liver, bone, brain, 90-something%, you name it. Once it goes to the blood, most likely BBLL, bone, brain, lung, liver. If it goes to the blood, which is obviously after the lymph nodes. Okay? Testes, chromosome number 12 is under study right now. They study it because of a possibility of hereditary causes for the cancer of the testes. Cryptorchidism is, we talked about this, it's going up in the pelvis, on the pelvic region, so it is warmer. This can cause predisposing factor to cancer. Tumor is hard and painless, and most of the time it's unilateral. Here is the rule of the thumb again. When you think about cancer, we mentioned that if it is painful, that's a good sign, right? Most likely it is not. If it's painless, most likely it is. That's one. Number 2, a hard mass is more toward cancer. Number 3, remember this, unilateral or bilateral? Which one is good? Bilateral is always good. Okay? If there is a mass bilateral, most likely it's not cancer. It takes some time to go from 1 to 1. That's most likely. It doesn't mean it's not. But bilateral is always against cancer. Unilateral is always with cancer. Okay? So unilateral, pain in the testes, hydrocele can form, epididymitis can develop. Gynecomastia, what does it mean? What gynecomastia means? Increase the size of the mammary gland or the breast in males. So the male breast start to look like females, kind of, a little bit. This is called gynecomastia, and this is hormonal disturbances. Increase estrogen. If it is in teenagers, that's normal, by the way. if you know a teenage who's having the breast tissue start to enlarge a little bit, it will stay for a couple of years and go. This is just hormonal disturbances. But in adults, that's something else. CT, markers, ultrasound, lymphangiography, all these tests can give us a clue about the cancer. Treatment, just like everything else. Surgery, radiation, chemotherapy, except if we're talking about reproductive system, if it is hormonal sensitive, you can use the hormones. Reproductive system. We have vulva, clitoris, vagina. I think we have a picture here. So this is a reproductive system. This is the uterus, fallopian tubes. This is the ovaries right here. This is the vulva. This is the clitoris, labia minora and labia majora. This is the vagina. This is the cervix. This is the uterus itself. Endometrium, myometrium, perimetrium. Okay, if you still remember this. Behind that, this is the rectum, and anterior to that is the urethra. And obviously, we know that the three systems are separated in females, but two of them are combined in males, right? We know that the urethra is completely separated from the vagina, so the reproductive and urinary system are separated in females, which is not the case in males, where it is combined. Okay? Reproductive and urinary system. So we have the uterus. This is to house the fertilized ovum. The cervix is passageway. Fallopian tubes, which is called oviduct. Ovaries, obviously, to produce ova and estrogen and progesterone. Breast to produce milk, and so on. This is the physiology. The menstrual cycle is from menstruation to menstruation, from day 1 to day 1. It's usually from 21 to 45. Menstruation is usually from 1 to 5 days. The average is like 3. Okay, and it's all related to the maturation of the ovarian follicles and the fluctuation of the hormones. The menstrual cycle, which is, what's the menses? What's lost during menstruation? The lining, but not the whole lining, right? The most superficial part only, okay, the peripheral part. And so the lining, which is epithelial cells and blood, is shed out. And this occurs if there is no pregnancy. Otherwise, the hormones will continue to support the endometrium. And we know that it's not the whole endometrium, right? During menstruation, it's not the whole endometrium. It's just a superficial layer. What's the normal position of the uterus? If you ever see like ultrasound or something, the uterus is not like this. It's like this. Do you know that? It's going anteriorly. This is called anteverted, anteflexed. It's like this. If it is pointing to the back, this is abnormal. Okay? So normal is anteflexed, like this. It is laying to the front, looking to the front. This is normal. If it is retroflexed, that's abnormal. So if you look at this picture, this is normal. This is anteflexed, meaning it's flexed anteriorly. This is retrocession. Retrocession means it's not like this. It's the whole thing pushed backward. This is retroflexion. So it's like this, the pointing to the back. And this is something for females, you might not even notice it. Unless you have like you're pregnant or something like that, you might discover it accidentally. But 90% of the time, normally is anterior. Sometimes it's posterior, and usually there are no problems with retroversion, retroflexion, unless there are some symptoms or something. Okay, this is normal. This is the first degree retroversion, second degree, third degree. Third degree is all the way on the colon to the back. These are the structural abnormalities. Prolapse. Prolapse meaning like this. If this is the cervix and this is the vagina, it's normal like this. Okay? If it started to go within, this is called first degree. Okay? If it started to push down all the way until it goes to the the entrance to the vagina, this is called second degree. If it protrude out, this is a third degree prolapse, right? We following? The uterus should be above the vagina. It goes within, first degree. Goes all the way, second. If it protrude, third. Prolapse. So here's first, second, third. Third is protruding out, and usually it needs surgery. Now, some females can have rectocele or cystocele. What celes means? Cyst. So cyst from the rectum that's going to the vagina, and the rectum is behind the vagina, right? Or cyst from the bladder that's protruding. So look at this picture here. This is cystocele. So the cysto means the bladder. Cele means cyst. So cystocele means a cyst coming from the bladder protruding to the vagina from the front, and this is from the back. This is rectocele, means a cele or a cyst from the rectum protruding, invading to the vagina. Rectocele versus cystocele. Now the menstrual abnormalities. What's amenorrhea means? No menstruation? Yeah, A means no menstruation. And amenorrhea can be 1 out of 2. So if a teenager go to the doctor, I'm not having menstruation, do you mean you never had it before? Or you had it sometime and then it stopped? If you never had it before, this is called primary. If you had it before but it stopped, it's called secondary. Okay? Dysmenorrhea is a painful menstruation. Most of the time, it is either due to ischemia or infection. Premenstrual syndrome. Some people, every time they have menstruation, the last couple of days, up to a week, before the menstruation start, they start to have tenderness in the breast, they start to have bad mood, they start to have some depression, abdominal discomfort, irritability, all these problems that occur in the week right before the menstruation start, and when the menstruation come, these symptoms usually relieved. This is called premenstrual syndrome. Okay, usually the treatment is exercise, limited salt, because the salt usually increases the tenderness of the breast. Sometimes they might need contraceptives or diuretics or antidepressants. Other types are menorrhagia, metrorrhagia, polymenorrhea, and oligomenorrhea. Menorrhagia means increased amount and duration of the flow. Okay, so the amount of blood that is in the menstruation is large amount. It should be, I think it was 3 to 5 centimeters or something like that. If it is more than that, or if it is increasing the duration, and instead of 3 days, now it is 10 days. Something like that, that will be menorrhagia. So the amount of blood at the end will be larger than normal, and it can actually lead to anemia if that's something recurrent. Metro means irregular. Metro means irregular. So metrorrhagia means bleeding between cycle. I have the menstruation day 1 to day 5 here, and then day 1 to day 5. In between, we shouldn't have anything, right? If there is a couple, 1 or more bleeding coming in between, this is called metrorrhagia. Polymenorrhea is short cycle. So like 10 days for the menstruation, another 10 days for the menstruation, squeezing the time in between, and this is the short cycle. They come every 3 weeks. Long cycle will stay for 6 weeks. And obviously the normal is, what's a normal cycle? This is the menstruation, but the whole cycle from day 1 to day 1. 28. The average is 28. It can be less, it can be more, but this is the average. So if it's go to 3 weeks or 6 weeks, that's shorter or longer, which is called poly versus oligo. Endometriosis, simply, where is the endometrium? Normal location. The inner lining of the uterus. And you're not supposed to have it anywhere else. For some reason, if you have this endometrium somewhere else, this is called endometriosis. What do you mean somewhere else? I mean anywhere else besides the normal location, which is the lining of the uterus. So this is called endometriosis. So it's ectopic endometrium. Endometrium, you have it anyway, it's lining the uterus anyway, plus somewhere else. Like what? Like in the fallopian tube, like in the ovaries, like in the rectum, like in the anything surrounding the uterus. That's called endometriosis. And the problem with endometriosis is it's endometrial tissue anyway, right? And one of the characters of the endometrial tissue is it responds to hormonal changes, right? So it becomes thicker and then become thinner and bleed, right? So we're not supposed to have this happening somewhere else. If it happen, it can lead to bleeding, pain, infection, and so on. And of course, it's going to cycle. So the complaint will be every time during the cycle, I start to have pain during defecation or during the urination, and I have some blood occasionally, and so on. And then when the menstruation is over, everything is fine. This is endometriosis. Okay, because it responds to hormone irrespective of where it is. The hormone will reach it anyway. And the treatment will be hormonal. Can be, if it is tiny, they can deal with it hormonally, suppress it. Otherwise, it should be removed. All these locations are abnormal locations. It can be like in the periphery here, instead of being inside. It can be within the muscles. It can be between the uterus and the bladder, the urinary bladder. It can be in the retrovesical pouch, or the uterine pouch, or in the rectum itself, or in the ileum. Anything surrounding it can escape and move away and go stuck somewhere else and stay there. Candidiasis, we talked about this. This is a normal inhabitant of the vagina. It should be there without causing any problems, and it's not sexually transmitted anyway. It can just flourish, cause infection of the vagina, and then heal, but it's not sexually transmitted. And actually, it flourished with the antibiotic therapy. So it's the opposite. It does not only does not respond, but actually it increased. It flourished with the antibiotic, or pregnancy or diabetes, which is the same thing for all other opportunistic infections. And obviously, Candida albicans. It's called the Candida albicans. What albicans means? It's a color, white. So this will cause white infection, white discoloration of infection of the vagina, if that's the case. Vaginitis, and again, it's not sexually transmitted. PID. So Candida, again, it will be red, swollen, and they will have white patches, curd-like discharge. The discharge looks like curd, and it is white. And the treatment is antifungal, of course. PID, pelvic inflammatory disease, inflammation of the pelvis, of the pelvic region. What's the pelvic region? Uterus, fallopian tube, ovaries. And infection usually ascending. It comes from outside, go through the vagina, so maybe vaginitis first, and then go into the uterus, and leave the uterus and go to the fallopian tubes, and so on. Most of these are sexually transmitted diseases. PID, pelvic inflammatory disease. Again, the PID is usually a complication of infection. So you have infection somewhere, started to spread, PID, pelvic inflammatory disease. The problem is if this is something chronic. So if this is a chronic infection, let's say for the fallopian tube. So the infection after some time, any infection, take it as a rule, this is a rule of thumb. Anytime you have chronic infection, it can lead to fibrosis. Anytime, anywhere you have infection for a long time, chronic infection, fibrous tissue will start to lay down, and it's going to close. If it is a tube, it will be closed. So it can close the fallopian tube. Anywhere you have chronic infection, it can become fibrotic. Complications can escape from the pelvic region, go to the peritoneum. It can cause an abscess, septic shock, and so on. And the most important thing about this is pain. It causes a lot of pain. beside guarding and fever. What's guarding? Guarding means you guard yourself, like like the doctor is trying to examine you. Go like, don't touch. Okay, it's painful, so you guard yourself. Why? Because a lot of infection inside. So this is called guarding. So it's different than pain. Pain, you have it anyway. Guarding, if somebody's trying to push, you start to contract your muscles to guard your inflamed organ. Leiomyoma, or called fibroid, this is a benign tumor of the myometrium. What's the myometrium? The what? The middle muscles of the uterus. So if a tumor happen in this area and start to go somewhere else, this is called fibroid or leiomyoma, and this is a benign tumor. Sometimes it's a single, sometimes it's more, and it's usually asymptomatic until it's causing something. And I know some people having fibroid and they are just fine, as long as it's not large enough to obstruct the lumen, for example, or to take the uterus to prolapse or something. It is benign tumor. So it can be here, which is called subserosal. It can be here, which is called endometrial polyp. It can be within the lumen here, fibroid. All this is fibroid, can go to the ovaries. So it's a tumor that can go anywhere, and the origin is myometrium. Ovarian cyst, this is a cyst of the ovaries. Most of the time, female having cyst, it disappear. Most of the time, it just disappear. Okay. Most of the time, it stay for 3 to 4 months, and then go, or 2 to 3 weeks. I mean, 8 to 12, which is 2 to 3 months. Okay. Usually, it goes like that and then disappear. If it stay beyond that, this is another problem. But the vast majority of the cysts disappear. It can cause inflammation and bleeding, and it should be surgically removed if that's the case. So if it is persisted or started to bleed or infected, then we have to deal with it. PCO, or polycystic ovarian disease, this is the disease of multiple cysts. The regular is one cyst. If it is multiple, this is something else, and this can cause a lot of things. Here it is. If you look at this picture, you see a lot of cysts within the ovaries. And the problem is it can demolish, it can occupy the whole ovary. So the ovary does not ovulate anymore. It can cause hormonal imbalance, infertility, absence of ovulation, amenorrhea, hirsutism. What's a hirsutism? Yes?
Is there a difference between the disease and the syndrome of the polycystic?
Yeah. Polycystic ovarian disease is just cysts within the ovaries. When you say syndrome, it means there are other problems somewhere else in the body, outside of the ovaries. So it can be something like a syndrome that contain polycystic ovary and polycystic kidney together, for example. So it has to be some syndrome is usually something else outside of this territory to call it a syndrome. So PCO, a lot of cysts occupying the ovaries, so it can cause amenorrhea, hirsutism, and the treatment is usually wedge resection. They go like this, wedge, and they cut the area that contain most of the cysts, or sometimes they can give medication. This is how the ovarian cyst looks like. Fibrocystic disease of the breast. This is a cystic disease, cysts that are surrounded by fibrous tissue, fibrocyst within the breast. This is usually a benign condition, but it can be cancerous. So if it has some atypical cells, it can be cancerous. And the density increase in self-examination. So females are supposed to do self-examination, I think from 35 and up, but if the density is increased, there are cysts inside. This is fibrocystic. And this usually it shrink and swell with the cycle, so it responds to the cycle. The cyst mass increase with caffeine intake. It's related to caffeine, it's related to the cycle itself. Carcinoma of the breast, this is usually after 20 years. Increase after 20 years, and most of the incidence between 50 and 69. Unilateral, the rule of the thumb, anything unilateral is more toward cancer. There are different types. It can be responsive to hormones or not. So again, the rule is any cancer in the reproductive system, you have to know if it is hormonal responsive or not. So that can affect the treatment. So this is carcinoma. The predisposing factors are hereditary. All cancer is related to hereditary. There are two factors that are called BRCA, BRCA 1 or 2. If this increase, it's a tumor marker. If that increase, it can. B is for breast. B is for breast. So BRCA 1 or 2, if it's high, it's related to the prostate. This is something in the genes. The main problem with the breast predisposing factor is a lot of exposure to estrogen. Like what? Like starting the period like at the age of 8, 9. So it's really long. And you stay with the menopause. The menopause does not come until the age of 55. So 50 years of exposure to estrogen. This can increase the occurrence of breast. Any overexposure to estrogen can lead to carcinoma of the breast, generally speaking, longer or higher. Nulliparous or late first pregnancy. So it's all about this. A lot of exposure to estrogen without pregnancy. This is the most important thing to know about the breast cancer. A lot of exposure to estrogen without pregnancy. So if you have the first pregnancy at the age of 35 or 40, this is long exposure to estrogen without pregnancy, breast cancer. Okay? Early menarche, late menopause, anything that leads to increased exposure to estrogen, this is one thing. Besides, smoking and high fat diets can also increase, and smoking and nulliparousy, they call it a magic prescription to breast cancer. They call it like this. Don't get pregnant and smoke a lot. You get breast cancer. They think about it this way. Because smoking and long exposure can lead to carcinoma of the breast. It's usually single. It's usually painless, right? Anything that's painless, the rule of the thumb, painless, hard, unilateral, one rather than a lot. This is always let us think about prostate. And if it is advanced, it will start to invade around and cause a regular shape of the breast. So the mammogram will show one single hard, painless. The breast tissue will start to change shape. Diameter will start to increase. If it leaves that, it will go to the axial lymph nodes. And the BBLL, just you name it. Every time you hear about metastasis, just say BBLL. Okay? Brain, bone, lung, liver. Treatment, remove it. If it go to the lymph nodes, remove it. If it is a little small part, remove the part. If it is larger, remove the whole breast. If it goes to the lymph nodes, remove the lymph nodes. Plus or minus radiotherapy or chemotherapy. And if it is hormonal responsive, that should be adjunct treatment. TMN system, do you remember the TMN system? What's a T? Tumor size. What's the M? Metastasis. What's the N? Nodes, yes. So they classified with the TMN classification according to which the treatment will start. Cancer cervix. The carcinoma of the cervix, most of the time it's related to the HPV. And that's why they do pap smear to girls or to ladies. Usually it should start at the age of 20 or in the year of start of the sexual intercourse. This is an advice that we always give to all girls. If you are 20, you do pap smear, okay? Or during the first year, you have to do a pap smear. The pap smear, they take a smear like a cotton swab or something. They take a smear from the cervix inside and they analyze it. This virus is notorious to produce carcinoma of the cervix. So if that's the case, if they take the smear and they see this virus, it doesn't mean you do have. It doesn't mean you have a carcinoma of the cervix. It means you can develop later on, okay? And there is actually a vaccine. If somebody is having this virus or something, there is a vaccine for HPV. So it should be routine. And again, the advice is if you are 20 or within the first year of starting the sexual intercourse, you have to do a pap smear and look for the HPV, human papilloma virus, notorious to develop breast cancer of the cervix. Okay, this is how it looks like. The cells, the virus itself, and the cells will start to become abnormal. And the course of the disease, when they do the pap smear, maybe you did it later, you didn't start early enough. So it goes like this. Dysplasia of the cells. The cells will change the shape a little bit. This is early. Then in situ, carcinoma in situ. Carcinoma in situ, what's in situ means? In the site, in the normal position. It didn't go anywhere. So carcinoma in situ is the second. So it started to make some cancer, but it doesn't go anywhere. It's in the normal location of the cells. This is called carcinoma in situ. Then start to invade the submucosa, and then they start to go to the mucosa, and then start to go to the cells around it, and then distant metastasis. This is how it goes. So start with HPV virus. If you leave it there for some time, it's going to play with the cells, causing dysplasia, carcinoma in situ, invasion to the submucosa, invasion to the surrounding, and then metastasis, which is very late. Okay, so normal, mild dysplasia, severe dysplasia, malignancy, in situ, invasive. Carcinoma of the cervix is usually under the age of 40, HPV, multiple partners, or starting the sexual intercourse in early teen age is another predisposing or a risk factor. Multiple partners, because usually during sexual intercourse, the body will be will start to tolerate or start to deal with the composition of this specific semen or other chemicals. If that changes for a lot of times, that's going to be irritating to the cervix, and it can start to do the dysplasia, start from this point. Besides the fact of more sexual partners, more risk of sexually transmitted disease, it doesn't mean it will lead to, it's just risk factor, increasing the chances of. Smoking is another thing, a sexually transmitted disease, and so on. Cancer of the uterus, it's usually in the postmenopausal woman. And the cardinal sign, the most important sign is painless bleeding of the vagina. Just bleeding that's happening not related to the menstruation or the menstrual cycle. It's painless vaginal bleeding. It's happening anytime. It might be a uterine cancer, and it's related to postmenopausal, a lot of estrogen, obesity, and diabetes. Pap smear have nothing to do with this. Pap smear is something specific for cervix because it's related to virus. Carcinoma of the uterus is not related much to virus. So it's slowly growing, but it can invade to the surroundings. And the treatment will depend on the degree. Can be surgery, radiation. This is the cancer of the uterus. Ovarian cancer. The problem with the ovarian cancer is It is kind of subtle, it's kind of silent because the ovaries is in a huge space. So cancer can occur and start to grow, and you don't feel anything until it start to give hormonal disturbances or torsion or start to compress something around it. So the prognosis is bad of the ovarian cancer because it is silent tumor. You don't feel it until it is late. And so it is an aggressive silent tumor. And they usually do a transvaginal ultrasound. They put the ultrasound through the vagina or through pelvic examination to find it out. Ovarian cancer, the risk factor, BRCA, same gene. Obesity, early menarche. So ovarian cancer is kind of related to the breast cancer. A lot of exposure to estrogen. Oral contraceptive, some people they used to do oral contraceptive with estrogen only, which is wrong. If a girl is taking, or a woman is taking estrogen plus progesterone, that's protective. So both of them combined, this is a good contraception. Surgery or chemotherapy is just like normal. Infertility is inability to fertilize. It can be due to males or females, and the normal sequence is you start with the male first. Let me get the semen. Let me see how many sperms. It doesn't have to be zero. If it is just less than normal, this is a problem. They analyze the semen and so on. If everything is normal with the male, then they go to the female and start to see the hormones first, the age. Are there any abnormalities? If there is infection, are you taking chemotherapy? The working environment may be exposed to toxins that inhibit the ovaries and so on. Sexually transmitted disease, chlamydia, is the most common sexually transmitted disease in the USA. Okay, chlamydia, most common sexually transmitted disease, which is called the chlamydia trachomatis. In males, it's called urethritis and epididymitis. Urethritis, obviously, infection of the urethra. Epididymitis is infection of the epididymis. And of course, being infection, pain, fever, discharge, and so on. In females, it's usually asymptomatic. Okay, and the problem is in males, it is symptomatic, but this is good, so you can take the treatment. And obviously, the treatment is antibacterial. In females, it does not produce signs. So what's the problem? The problem is it can be aggressive. It can move on to PID, and you don't discover it until you have infertility or something like that. That's it in females. So start asymptomatic, and it can actually infect the fetus during delivery. So it can be acquired during delivery. Gonorrhea is number 2, and it's called by Neisseria gonorrhea. And some of them are resistant to penicillin and tetracycline, so they started to use different combinations. In males, again, it causes urethritis or asymptomatic. In females, again, usually asymptomatic. So they discovered it later on. They discover it after it goes to PID, pelvic inflammatory disease. And again, it can affect the newborn during delivery. So it can affect the eyes or go to the nose or something. This is gonorrhea. And of course, the treatment is antibacterial. And it can travel actually and go to the joints. This is just summarizing everything that we talked about. Syphilis is the next one, and syphilis goes in 3 stages. It's a sexually transmitted disease. Okay, so the most common is chlamydia. We talked about gonorrhea and now syphilis. Sexually transmitted disease. The primary stage, it just causes painless ulcer. Painless ulcer. Okay? So this is the primary stage. It's called chancre, and this is what we need to remember. Syphilis, primary, secondary, tertiary. Primary, what's the most important? Painless ulcer. That's called chancre. Number 2, secondary, rash. Okay? Rash. And it is contagious during the first and the primary and secondary. This is a painless ulcer. This is chancre, and this is how it looks like. Okay. Secondary start as flu-like and then rash. Flu-like, like rhinorrhea, like coughing, sneezing, and so on. So this is the secondary. What do we need to know about the secondary? Two things: flu-like and rash. Flu-like symptoms and rash. Latent. This is can transmit the disease. The tertiary, which is the final one, is irreversible, and the organ here and the lesion here is called gamma. So what's the primary? Chancre, painless ulcer. What's the secondary? Flu-like and rash. What's the tertiary? Gamma. Gamma is a fibrous tissue in different organs. Later on, it can affect the brain, go to dementia, and blindness, and so on. Sexually transmitted disease. If the baby is born to a mom who's tertiary syphilis, which is a late, he can get syphilis that's irreversible. Treatment, antimicrobial, just like all others. Viral infection can be caused by herpes, type 1 and type 2. Type 1 it's usually the cause of vesicles that can happen around the mouth, but if somebody's having oral sex or something, it can actually transmit type 1. Type 2 is actually reproductive system virus. So type 1 is a reproductive, type 2 is oral, but it can cause some reproductive or type just like type 2. It causes some pain and itching, and it can go back to the root ganglia. We talked about this, right? The first time you're infected, go to the ganglia, stay there, and then it can go to the periphery, causing these problems, and then go back, and so on. This is in male and female, how the herpes looks like. It's painful. Can be reactivated. If during stress or illness or menstruation, this is where it's reactivated and then go back to the ganglia, and then again you have a stress or infection or something, it can be reactivated. Antiviral drugs is used to treatment just to suppress the virus. It does not eliminate the virus. It's usually lifelong. The herpes is usually lifelong. And for prevention, condylomata, this is another warts, genital warts, and warts means overgrowth. That's called by HPV. Trichomonas, this is a protozoa that can cause infection that's asymptomatic, but it can go to symptomatic. And that's it for this chapter.